our next section, we're going to talk about opioid rotation, or converting between opioids. Now, this is done for several different reasons. One being, sometimes patients may have a lack of therapeutic response to one opioid and may do better with another. So, converting between opioids is a way to do this. Another is if you are exceeding the maximum dose of combination products. So, if you have too much Tylenol, if you're taking something like a Norco that's Tylenol and hydrocodone, sometimes you will want to convert to try to avoid that. Also, adverse effects, and then changes in patient's health status. So sometimes if a patient goes from being able to take things by mouth to needing things either liquid or intravenously. So whenever we're converting, we always want to calculate the 24-hour dose, considering all doses received. Then choose an agent, and this can be based off the agent or patient characteristics. For most cases, we will tell you which agent you're going to. You want to do the math, which involves cross-multiplying, so we'll cross-multiply and solve for x. And then you want to adjust for Crow's tolerance. Now, this can be anywhere between 0% if a patient has really poorly controlled pain, to 75% in a patient that maybe seems over-sedated. For most patients, we do pick 50%, and that's what we're going to use most frequently in this class. Next, you want to give a dose for breakthrough pain. So that can be anywhere between 10 to 20% of the dose you did. Selecting a product will require us to know common dosage forms, and I will give you guys a little cheat sheet for that, and what you do, I'll show you how to do that here in a minute. And then finally, we'll monitor for the effects. Now, whenever we are doing conversions, it is important to remember that there are certain conversions that are a little bit more difficult between opioids. This includes patients that have non-injectable fentanyl, patients on methadone because it has that MNDA therapy, tramadol because it has serotonin-related effects, and that what makes it hard, and then extended-release hydromorphone based on the release mechanism. Also, conversions are based on limited data, primarily single-centered studies and pharmacokinetic data. And there are patients at higher risk for ADEs, adverse drug events, that we need to consider, including elderly patients that are cahexic, meaning that they're low weight, aren't malnourished, etc., etc. Pediatric patients, patients with renal and hepatic disease. This is the chart that you'll use to try to convert between opioids. You'll see that there's your opioid here, the dosing for parenteral or IV therapy, and dosing for oral therapy. We'll use these, and I'll show you how we're going to use it here in just a moment. So I think the best way to do these is to learn by doing cases. So let's do this case really quick. So this is a 45-year-old female who's been in your hospital following a motor vehicle crash. She's ready to go home, and they want to put her on oxycodone ER for ease of dosing. So as mentioned before, first thing we want to do is calculate the total daily dose. So for this patient, the total daily dose is going to be a combination of these morphines from different sources. So first they're getting morphine, 15 milligrams, Q6 hours. That equals 60 milligrams per day. Correct? Then they're getting morphine, 7.5 milligrams, Q6 hours, PRN. And they said that they've been using that all their doses, so 4 times per day. So that also would equal 30 milligrams. So we combine these two to get our total morphine. So they're getting 90 milligrams of morphine per day. Next, we want to know what our agent is that we're going to use. Now, they already told us that we have to use oxycodone. So that means that we can skip to type 3, which is, let's do the math. So, we're going to set up a conversion calculator here. So, we're going to do this equals this. So, as mentioned before, we know that 90 milligrams of morphine is what we have. What we want to figure out is how many milligrams of oxycodone that equals. Correct? So, now we're going to have to use our conversion factor in this one to know what milligrams of morphine equals milligrams of oxy. So we'll go here and we'll find our morphine oral milliequivalent, because that's what we're using, and our oxycodone. So that is 30 to 20. So for every 30 milligrams of morphine, we want 20 milligrams of oxy. And you'll notice that these line up. Equals, 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 equals. Oxy's on the top, morphine's on the bottom. You want to cross multiply. So 90 milligrams of morphine times 20 equals 30x. Divide both sides by 30. And what we should get is 60 milligrams. Now, as mentioned before, the next thing we want to do is, sorry, I want to make some space for myself here. Let's make some space for myself here, is do a reduce for cross tolerance. So for 60 milligrams, we want to make sure that we're reducing by, for most cases, 50% reduction. So 60 times, and just for your care and to be like super safe, I would do 100% minus 50%. That way, whenever you do a 25% reduction, you know you're taking 75% of the dose. So 50% of 60 is going to give me 30 milligrams, and that's how much of the long-acting we need. Next, we're going to want to calculate for our breakthrough pain. So as mentioned before, that is about 10 to 20% of the dose. So we're going to do 30 milligrams times 0.1 or 10%, and 30 milligrams times 0.2, which is 20%. And that should give me 6 milligrams and 3 milligrams. So we know our range is between 3 to 6 milligrams of oxy for a breakthrough pain. Now, next on our list to do is to select a product. You guys are linked a sheet that gives you all the common dosing formulations, both long-acting, as seen here, and short-acting. You're going to notice that they have available preparations, what the brand name is, and then also the usual dosing interval. This is going to help us as we try to decide what our frequency is. Now, let's go ahead and go back to our patient. So what we got was 30 milligrams of ER. So whenever we look at this sheet, we're looking at oxycodone ER. So it comes in all these different doses, and it's Q12 hours. So we know that we're going to have to divide this into 2 equal doses. Luckily, we have this option for 15 milligrams. So we can do 15 milligrams of oxy IR BID. Next, we can look at our short-acting formulations. Also set up in a very similar way with your usual dosing interval, what it's supplied as, and formulations. You see that we have several different options as far as oxycodone tablets. This patient, we can probably just use the regular tablets. We don't need the liquid. And it comes in 5, 15, and 30. And it can be dosed every 3 to 6 hours. So going back to ours, we got 3 to 6 milligrams. So we can probably pick right in the middle of that range and do 5 milligrams. And again, you can do anywhere between 3 to 6 hours is appropriate. I'm going to do Q4 hours PRN for breakthrough pain. And I just picked 4 hours because it was right down the middle. Again, we're going to do some more examples of these cases next in a couple weeks.